Hello and welcome to the Dental Labcast. My name is Jenna.
My name is Andrea.
Please follow and subscribe to support our show and to make sure that you never miss an episode.
Welcome to the next episode of the Dental Labcast.
Hello and welcome to today's episode. We've got Rowland Gardner. Hi Rowland, thank you for joining us.
Good evening.
Can you just explain who you are and how you got into dental technology and when you got into dental technology and dentistry?
My name is Rowland Gardner. I've been a dental technician now since I started training in 1972. And I very much just born into this profession. Got into it by mistake, as most people do, or without, I wouldn't say by mistake, but ignorance, really. You never know quite what dental technology is about. And still you get people who don't. And this is why we do all these school visits, trying to promote our special profession. I managed to get into it because my leaving school, well, they've taken the O level, GCSE level, or GCE as it was at the time. I was just about 15 because you could leave school before your 16th birthday. So I took my GCSEs and whatever, determined not to stay at school. I just wanted to get out of school. School wasn't an unhappy place, but I wanted to go out there and do some work and be a man. My father passed away, unfortunately, when I was 10. So we had, I just wanted to go out and be into the world. No idea what I wanted to do, but a friend of mine went to Australia. In fact, he immigrated to Australia. His name was John Russell, and he ended up as the chief technician at Lytton and Dunstable for many years. He came back from Australia because he got threatened with, or there was a situation he may have been called up to the Vietnam War. He came back and they moved to Surrey into a small, I think it's a caravan or some sort of park home. And he went to the local college, which is Brooklands, and they had you become a tanner, or you can become a dental technician. Or I think it's a farrier. Sorry, a farrier. So he became a dental technician. He gave that a go, and he absolutely loved it. Word got out that he's 2 years older than me. That it's a fantastic job, and so interested. He's telling my mum about it, and she said maybe you should suit you, Rowland. So I went to college at Tooley Street and got enrolled as a full-time student. Very fortunately, a chap called Eric Wedstone, who was Uncle Eric, is a fantastic lecturer. He's one of these legends of our profession. He said, you know, son, as he said, calls everyone's son, they've started to pay for training at the London hospitals. Okay, so I came home. I said, well, I've got a college place, Mum, but, you know, they started to train at the hospitals now and get paid for it. Mum at the time was a senior nurse at King's College Hospital, London. King's College Hospital, where I'm working at the moment. The history of King's go way back in my family. So she sort of made some inquiries, got the form, filled the form in, and got interviewed at 15 by Professor Ken Lidlow. He was a marvellous man, one of the great sort of prosthodontic prosthetics. The book of Fenn, Lidlow and Gibson is quite a Bible with prosthetics. So he's very much revered. A great man. Interviewed by him, he said, you should stay on to do your A-levels because your academic ability. I said, no, don't want to. So I didn't. And he gave me a place to train as a dental technician starting in September. So I was 16 and 1 month when I started. And didn't really have much idea what I was letting myself in for. But, yeah, let's give it a go. And I can't ever remember thinking I shouldn't be doing this. It seems to be, it just slotted in. It just fitted
You just feel really natural.
Really. And quite interestingly enough, there's a guy I'm following at the moment called Sir Ken Robinson, and he's written a book called The Element. In fact, I have it here. And he writes that book is really about finding your element. And if you find your element in life, you never really need to work. It just becomes you. Well, I was very fortunate. I believe now, after 54 years, it hasn't taken that long to realise it. But reading that book, I found my element when I was 16. Very much like the profession. It's just, it's been very, very good to me. Never missed a day's salary, which is, but this is why I really can only talk about being a hospital technician, about college lecturer, about the education system. That's my forte. It's not really about commercial laboratories. I'm not sure I would have survived. I would have stuck with it if I'd gone into the commercial world.
And why do you think that is? Why do you think you would have found it so much more challenging? What aspects of
Well,
it?
there's all the stresses of running a business. It's getting the money, really. That's they're chasing the money. I hear so many stories now. Facebook is so rife. Technicians it's their business, their livelihood. If clinicians and dentists are very slow in paying for their work, and it seems often they are not. There's some great relationships out there. It matters. You've got a mortgage to pay, and a family to bring up, and you're not getting the money in, then it becomes very stressful, and it takes the enjoyment out of doing the work. In the hospital environment, I'm not slow by any chance, but you take as long as it takes to do that proper job. So you do it to the best of your ability, to the gold standard, and that's it. And that's what's expected. Commercially, there is the pressure of the money and the speed and the long hours. Having said that, I've done many long hours, which I'll come to later on. In fact, my work myself into a double heart attack when I was 60, so we'll come back to that later.
Wow, blimey. And you're right. I mean, like commercial laboratories, they are businesses. And I think it should be an aspect of dental technician training, actually, sometimes. Yeah, it'd be really useful to have, I think, a module as part of the qualification, even if it just touches on the basics of business, because a lot of people, they do leave and they either set up their own business or they go and work for somebody else and need to understand why they're put under certain pressures as well and how to deal with it. You don't really get taught the business skills, do you? There's a lot of technicians sort of get thrown in and then they're struggling because they just don't understand that side. Or don't, because we don't want to do that side a lot of the time, do we?
It's right. I mean, it's well known that lab technicians aren't the best businessmen sometimes. Some are, they're great, but often they're not, because they love the creative part of it. It's in their mindset, it's in their DNA, not being. And those that are find themselves as lab managers and not the best technician, but they're the good businessmen, the good communicators, and they bring the work in, and they get a team of good technicians around them to produce the goods.
Yeah, I think you've been in commercial all the time, haven't you, Jenny? You've not done any technical work.
No. Actually, when I first started, I wanted to go into hospital work. I actually wanted to go in and get into maxillofacial, actually, which is what you do, isn't it? You are head of the maxillofacial.
Yeah,
sorry if I'm saying it wrong.
No.
Technical services.
No. See, that's So what happened? So yeah, I was trained at King's. I did my 4 years training at King's.
Yeah.
Or three and a half really. So I finished in June 1976. So I started September 72, finished in June 76. You could not have written it. I left King's and went straight at Queen Mary's Sidcup. Queen Mary's Sidcup was a new build. It's an old hospital. That's where all MaxFac started with Harold Gillies. That's where all the facial reconstruction started. That's where we're famous. And they say that East Grinstead, they did some fantastic work during the Second World War with the burns. The First World War, we get horrendous facial injuries. Faces ripped apart with skin gone missing, left on the ground with wounds full of mud. Came to Queen Mary's with Harold Gillies, and he developed this tube-pedicle facial plastic reconstruction surgery. So Queen Mary's is an old hospital. That's maybe another podcast. That fascinates me. And they moved the old huts which were asbestos huts, from the old part of Queen Mary's into the new build in 1968. I think it opened up, and they had a dental department there, and there was the technician, and they advertised for a technician. Brother, fortuitously, was a assistant hospital secretary, they called him. He was 2 years older than me. He's progressing through his hospital administrator training. That's why him and we never see eye to eye, we chalk cheese. It's a strange, it's a great relationship, but he's very much different. He was at Queen Mary's at the time and said, they're looking for a technician here at Queen Mary's. I said, yes, I know, Alan, but, we're looking for someone who's experienced. I want to set up a lab. I'll get you a form. Oh, well, we'll get it anyway. Okay, I filled it in. And again, the rest is history. I got the post. It so happened that the consultant at Queen Mary's was also a consultant in orthodontics at King's and knew of my work.
Right.
He said, right, you'll do for me. Thanks very much. And I said, is it 19? I was 1976. This open space and said, well, can you set up a lab here? And I did. And that was Max Fac. So then we talked about this Max Fac situation. The days of trauma, steering wheels, seat belts not being worn, traces on steering wheels going through windscreens. And we not going to big it up. We had maybe 2 or 3 of them a month. We had Brands Hatch. We had some cup racers in from Brands Hatch, quadriplegic. In fact, it's still a very good friend of mine. And other racers had crashes. That we did trauma. Basically, Queen Mary's is a trauma centre. Max Fac was part of it. So silver splints, all these wonderful skills, and I talk about throw yourself in the deep end. Nobody really showed me how to make a silver cap splint. I had to go back to King's. They told me. In fact, tell a lie, I did make one at King's. It was during an August. No one was there. All the technicians had buggered off and went on annual leave. And there was only me in the lab. One of the tutors said, show us to make a splint. You can help me make it. So that's how I knew how to make a silver cap splint. And we did quite a few of those, facial scaffolding, all sorts of great things we did at the time. And this was a solo lab on my own, working lots of hours, thoroughly enjoying it, absolutely reveling in it, all the nice equipment, materials, great team, great consultants to work with, and some great friends, people I'm still friends with. They're now professors and head of this and head of that. Queen Mary's has been been very, very good to me. It really has. But during that time, because I was a solo lab, the training was advanced sitting guilds. And so I went back to college to do I think the first one was orthodontics with Bert Aldridge, great Bert Aldridge, another renowned technician. In fact, I spent a few weeks with Bert Aldridge in 76 because the lab wasn't quite ready, and the orthodontic consultant sent me to Great Ormond Street to spend some time with Bert. So I was very blessed with 6 weeks with Bert, really. And then we did the advanced ortho. And of course, what followed on from that was the advanced maxillofacial qualification, which I got. And see, then it was kind of worthwhile doing. Because first of all, I enjoyed doing it. I just enjoyed going to college once or twice a week. But then you'd get from dental technician to senior dental technician. And then you go from senior technician to chief dental technician with the third one, which is the prosthodontic one. And I decided to go for the Corona Bridge as well. So I got all 4 advanced qualifications and became senior chief at 29. So good salary. In 10 years' time, from 19 to 29, 10 years of absolute, just going for it. Really drinking all that knowledge in. And of course, at that stage, the college said, Uncle Eric, who I mentioned earlier, is retiring with Alf Gow. And they were positioned there for some lecturers at the college show. I said, you know what? I think I'll go for that. And one of my good friends, who's I won't name drop, he was a colleague at the time. He said, "You sure you're up to this, right? Have you done any public speaking? Do you know?" Well, I don't know. Give it a go. I think I don't know the subject. And so I got the job as a full-time lecturer at Lambeth College, or Norwood Technical College as it was at the time. Now, there's a thing. So going on from there and talking about education and my thoughts on this is that I studied all the textbooks. I read all the old textbooks, the Farrell, Skinner's, spent quite a lot of money on books and read up on it, and managed to pass all the qualifications and exams. But when you get to teach, you realise just what you don't know. You really, because the students are asking you questions, you think, you know what? That's what I was taught. It just doesn't make sense. So you then have to really look at it closely and realise that some of the stuff was old wives' tales. This old stuff that's passed on from generation to generation. So old John taught me, he's been doing it 50 years and, he's a really good technician. He's doing it 50 years, but he's not been doing it right. He's been doing it his own way. and he's passing on the bad habits, or passing on his way. So there again, fantastic, inspired my enthusiasm for the profession even more. Get quite good at dental science. I found that quite incredibly interesting, and realised all those wasted times of doing physics and chemistry at school, which I didn't think it would be interested in or any good to me. Found that it would have been really good to me. So I had to sort of backtrack a little bit on my O-level stuff on physics, chemistry, and biology. But it's fascinating, and I really enjoyed learning even more. And of course, on top of that, we had to do this postgraduate Cert Ed qualification, 2 years of that, which it's very demanding because it wasn't a technical qualification, which I found quite easy. This was an academic qualification, first one, which it's challenging, but I managed to get a distinction at the end of it because I really had to. I remember times doing these dissertations, these assignments. I think I just don't get it. To really dig deep to get to that academic level, which we have at the moment. And I think one of the problems or failures really of our education system at the moment, and I know because I was there at the time, was the transfer from sitting guilds to a BTEC. That in itself was a fabulous move, and our profession needed to go that way. But the practical element was somewhat diluted because those two liberal studies and all the other add-on bits they had to comply with the BTEC curriculum. And it got even worse when he went to degree, because quite frankly, the practical content of the degree is woefully deficient, what it should be, and far, far less than we did. I mean, advanced sitting guilds, you just sit in a 3-day practical exam with things thrown at you, and you just got, and also the written papers. It's far more demanding, technically. But we are where we are, and we've got to really make the best of it. So I've sort of scooted along a little bit among my career, from a technician to the Max Fac, and still enjoy joining all that.
How do you think the apprenticeships are falling into that
Fantastic.
now? Is that
That bloody time. So you can bleep that one out.
no? It's fine. You got it in.
Keep it in.
No, that's exactly as it should have been for a long, long time. Now, see, I was very fortunate. I was trained in the 4-year. I was paid 4-year training at a dental hospital. The London, it was always the gold standard. The London one was always the gold standard. And I'll share something with you now. The original BTEC curriculum was written by some very, very caring and dedicated professors and surgeons from Guy's and Royal London and Eastman and King's. They put together the original BTEC program, which I've got. It's far too big. It's massive. You can't take it all. And that's all these modules. It really goes into great depths of detail. But it's a fantastic program. And over the years, it's been diluted because of time, because of money, because of interest. And the concerns that I've got really is that you're asking people with 3 A levels to come into a profession, which it doesn't shine out as one that says you can earn an awful lot of money out. It's people. It's not a high earner, and you're going to go to university, and now, of course, you're going to have £9,000 a year university fees to get through a degree course. It's gone complete. It's gone bonkers. So the apprenticeship is fantastic. Well, thanks to David Smith, he's done a wonderful job down at Yeovil to really highlight that. So the laboratories now can have their own apprentice. All the college fees get paid by NHS England, Department of Health, Department of Education, and they get £2,000 a year for actually. I think it's £2,000. I don't know if it's a year or not, for taking on an apprentice. So what's there not to like, really? It's just encouraging people to come on board and train as a technician.
Yeah. And I think for a long while, I know a lot of people who weren't impressed with the degree, and they didn't want to take anyone on who got especially if they've done a full-time degree, because, they were saying this is a very practical, hands-on subject. And people are coming out with a degree expecting top dollar for, our banding, especially when you start out, but they're expecting top dollar and they haven't actually got the bench skills. You're having to teach them the actual practical skills. So they knew plenty of theory, but there was a lot who, we had a guy come to our lab. We had to teach him how to use a pair of scissors. It was bizarre.
Wow.
I couldn't believe it. I was like, how do you even wrap your Christmas presents if you can't use a pair of scissors?
The
It was
left-handed or
bonkers.
right-handed?
He was right-handed. Yeah, he wasn't, because he was left-handed. He
We
just
we
just
got
not
this.
practically minded at all. But he was very academic, and I think he actually went into material science and didn't bother doing dental technology in the end at all. But yeah, I
Seems to be
think
a running theme with everything in dentistry, doesn't it? Because the same happens on the clinician side. They've kind of dropped out all of this practical and it's become more theory led. And, people are struggling when
I
it
think
comes
they're
to actually
relying on
getting the
when you
hands
actually
on.
get hands on when you start, but it's a bit more dodgy doing it
But
that way.
then when you're getting into these places, so if you're getting into a lab or if you're getting into a hospital, then you're not exactly trusted to be hands on with something without being supervised all the time. It just kind of makes things more. I think it makes things more difficult. So, and do you think, Roland, that with all these changes to the education, that is one of the main reasons that technicians have stopped going and applying to be a dental technician on courses?
There weren't many opportunities anyway, were there? Really, I mean, people were taking the labs. From COVID, the labs are really hit. I mean, COVID was really good for dental technology, dental technology, really. Maybe I'll come back to that in a while, but it's always been on the slide. It's never. I mean, who knows about dental technology? It's just a question of, who says I want to become a dental technician? I never said that. Who else ever said that? Or I want to become a dental technician. It's fabulous. Only the people who maybe their father was doing it, or their family member was doing it, or they kind of know about it. But these are very small areas. I mean, the people I've trained to be technicians. Obviously, I've got good knowledge about why did you apply for this job? Why did you apply for this course? Well, of course, that would be the course that they get paid for in the hospitals. A number of them were they had a family member in dentistry, and that was why they thought it might be a good idea. And they weren't too sure about being a dentist, but they would be a technician instead. They'd be more suited to the skills of their knowledge.
So
So
you said you go into schools. Have you been going into schools to try and raise awareness of this? Do you do careers events, that kind of thing?
one done recently down at Chatham Victory Academy, six formers.
Mm-hmm.
Yeah, with a hygienist, Miranda Steeples, and one of our senior nurses at the hospital came along. So all three of us did sort of a 20, 25 minute stint about why what our job is about, what our profession is about, and just try and encourage you. Really, I suppose really that was coming to look at dentistry. That was the crux of it, because it's not just about doing teeth. You can go off and do lots of other things. Oral hygienist, dental technician, you can this therapist, that therapist. You can use that degree, the dental degree, to go to other areas of medicine or other healthcare professions. So use maybe a dental degree as a vehicle, as a conduit to do other things. You're not just being a dentist for the rest of your life if you get qualified as such. So that was the main thrust of our presentation in schools. I think it's the way to do it, because they look, you show them a false ear, a false nose, and ear, and all wonderful, clever things, and models of skulls with holes in. It's all, oh, that's really interesting, but I don't think they ever take it up. And it's a long way off. And Jenny was talking about max fac. I think I can say this: I'm a max fac technician, I'm an ortho technician, I'm a prosthodontic technician, I'm everything. I think max fac has all been a bit too sexy. And the opportunities, the proper max fac jobs are few and far between. People like to do it, and they got this masters, and that's a hell of a program. And thankfully, like Chris Marion set that up at Manchester. Of course, once Manchester was no more, then they're having trouble filling that course. And Trevor Kings, Trevor was a hospital trained technician. He was a couple of years behind me. I think I'd left a couple of years when Trevor started his dental technician training at King's. But they've done very well. I mean, and I went into academic study and become an academic, and fabulous. And that's given Trevor, as an example, that vehicle, and others I know, the vehicle to expand their academic ability, and come away from the bench to some extent, to develop skills in dentistry. So it gives opportunities, but would I recommend someone going into dental technology now? I'm not entirely sure that I would, but there are some great opportunities ahead of us with all the digital technology. It's going to be different. It's going to be very different.
Would you say that you wouldn't really advise people to go into dental technology as in like a commercial side, or for hospital side as well, for everything?
Well, I don't think hospitals are really recruiting. They're not training any longer, which is a shame. That hospital training scheme packed up in year 2000, and it proves it, because we have now, we know the figures that's the banded about that most lab owners are over 50 or that sort of stuff.
Yeah.
Well, most hospital technicians are late 40s, 50s, because there's no one behind. See, I left hospital training. I was a tutor at Guy's, and I left there to manage a department at Queen Mary's. To manage the department, not the lab, the whole department. Secretaries, hygienists, surgeons, the whole lot, which is a fascinating experience. And I'm kind of glad I did it, because I had no choice. I'd love to stay to train technicians at Guy's, but there wasn't going to be a course. They were going to transfer everyone over to King's, they're going to merge it all, and downsize that, and eventually the hospital was no longer funded training. And from that moment on, which is about 2002, which is nearly 25 years ago, there's been a void. There's been a vacuum of no one coming through the hospitals. And people are sitting there on their jobs. Now, sort of, 50, maybe I'll retiring soon, or in that kind of. There's been no succession planning. And I don't think the hospitals are that bothered, really. Think about outsourcing, and again, this is that. You've got 3 or 4 podcasts in me, I'll tell you. That's what they tend to do. So
there have been a lot of hospital labs which have been closed over the years. So, I know of quite a few where one of the bigger hospitals in the area has taken on all the work from the others, and then all those smaller labs have been closed down. And once they're gone in the hospital. They're never going to put them back, are they?
Absolutely. Yep.
So, they've gone. So, and I've seen that quite a lot. It almost feels like hostile takeover. If you're the big fish in that area, like a survival thing, you're going to start trying to take all the work from the others. And as you say, as people retire, rather than that hospital taking on new people or succession planning and training people up, they'll just send that work to that other side. So it has been happening a lot, I've noticed. But even in our department as a whole, there's me, I run the lab on my own. There's nobody else in the lab with me. And I'm in my 50s. We've got so many of the nurses and the therapists who are also late 40s, early 50s. In a few years' time, they're going to have a recruitment crisis because half the department's all going to retire at once. It's going to be crazy. But, hospitals don't seem to be having apprentices in our field and training them up and having that succession planning. So I don't know what they're going to do. They'll have to just go out to the commercial labs, won't they?
Seems that way, because nobody wants to. Well, just looking at the dental side of things at the moment, there's big arguments about NHS pay, isn't there? So when you've got your therapists and people like that, they're not going to leave a private clinic or anything, unless they're kind of forced to after coming out of some sort of training where they have to work in an NHS field for so long first. They're not going to. I don't think they'll opt to go into an NHS.
No, but I also think like working in because I've worked in both. Started out in sort
Yeah.
of private dental lab, and then I intentionally moved into the NHS because I didn't want to be involved in that business side. I wanted to be involved in just giving people the care regardless of the means. So
Yeah.
that was my motivation why I moved. But it's almost like we do have a different skill set within a hospital because we're exposed to different cases. And as Rowland says, it's like quite often more complex cases, it's trauma cases, it's cases that can't be dealt with as easily out in the community. So they are sent through to the hospital. So
It does
it's
seem like you're a
challenging.
higher skilled bunch of technicians, really, in
We get to
hospitals.
think outside the box a bit more,
Yeah.
I think, because we get, called into the clinic. I've got this case, it's a bit weird, it's a bit complex. This is what we need. And it's quite often medically complex as well, not just the dentition or, that dental environment. So it is a different skill set being a hospital technician, isn't it, Roland? Do you feel the same as well?
Well, very much. That's why hospital dentistry exists, and this is why we shouldn't be doing the simple stuff. The simple stuff should be triaged out away back to obviously at the moment the dentistry is becoming very expensive, and if someone can manage to get their treatment done in a hospital for free, they're all there. There's all sorts of things. But there's plenty of work. There's so much work coming through, and complex and difficult cases, and it's nice to have that to do. And we do have to think a different way about treating it. As Andrea said, it's not only what the dental condition presents; it's their medical condition. It's their medically compromised. They're all sorts of and we can give very, very good service and get these, and it's very efficient as well. There's no doubt about that. Then I went on to, the CDT thing was quite. I was really pleased I did that because that added another aspect to my.
Is there any? I don't think there's any aspect you haven't done within dental technology, is there? You've ticked all of the boxes.
Definitely versatile,
So I
multitasker.
was wondering if I should have done a master's or something along the way, but I
Did you have time?
twice. But becoming, as I said before, the transition between doing advanced qualifications and then going into being a lecturer and learning even more about. I didn't think I knew everything. No way, I was arrogant. But I had a reputation that the students would want to because they knew this guy has got 4 advances. Nobody's done that before, so I had that reputation to help me. But I had to learn an awful lot more. And then again, when I did the CDT course, you don't think you know it all, but the CDT course was really more about patient management and all the other aspects of running a clinic. It wasn't about making dentures better, although of course you did, because you have to learn all the clinical skills, the functional borders, all the impression techniques, and everything else that you consider when making a denture. That is really aimed at making complete dentures. Although we did a hell of a lot of partial dentures, and we did radiography, and we did all some other things on that course. So I came away from that thinking, it's now it's another level, and I enjoy it even more. Of course, I can go, and I often go into clinics now. I come in most days now to see the case, and I've got a good relationship with all the consultants I work with, and I don't step on their toes, and I'm there to be an expert at certain aspects of their treatment. It's sometimes tempted to take over the clinical management of the patient. I think, I want to done it that way. I'll just give the advice and it works very well, and it's very enjoyable, really most enjoyable. So, and I don't. My working week at the moment is Tuesday, Wednesday, Thursday. But we've got an interesting case on at the moment. Consultant, she works Mondays, so I go in on a Monday when that patient's coming in. So I'm very fortunate I can sort of flex my week that way around. But it's just I'm saying that sort of thing to highlight my enthusiasm for dentistry, and making smiles, making people cry when they put their don't mean it intentionally. They walk out and think, I don't believe it's been done so many years. I haven't had this, and now I've got this. And it happens. It happens on a number of occasions. So yes, thoroughly enjoy it.
So at the moment, Rowland, are you doing more dentistry side of things, or are you doing maxillofacial, or is it a mix of both? Can you just...
Well, one of my thing, like we did about 1,000 cases, done about 100 cases a year of orthognathic surgery, and had my own special way of doing a lot of technicians have developed their own way of planning surgery. This is before the computer.
Can I just stop? What is Sorry, how do you say it?
Okay, so it's,
can you just explain what that is for anybody that doesn't know? Probably like me, who never heard of it before.
Changing faces. People who are asymmetry, bigger lower jaw, small lower jaw. It's a disproportion, and often these patients live with their features, their lack of confidence, don't know how they look, and often they come along with a tooth, the tooth that needs extracting, and we say to them, do you realise that we can do something about this? And we've become quite a centre, one of the biggest centres for orthognathic surgery, Queen Mary's, with a chap called David Young. And we're doing up to 100 cases a year, it's 2 a week, planning them up and getting them through this conveyor belt of surgery. So something else I really, really enjoy doing. But, sadly, in a way, that's been taken over now by virtual surgical planning on computer.
Yeah.
So I do, and tonight I was uploading a few cases, all the intraoral scans, the final position, the CBCT scan, prescription, and upload it to a company who then do all the planning, discuss it with a consultant, and they provide all the hardware for the surgery. Occasionally, we still make it. This is why it's quite good to have that skill set, because a few months ago we had 2 cases on a Thursday. One work was sent across for surgery but got lost, and the other one, the surgeon forgot to plan it on the Wednesday. It's right. Really?
We're doing a mix of that as well,
Okay,
and it's.
so
have you got surgeons who are a little bit wary of the digital side as well, or are they embracing it?
On that one, but in these cases, I got 2 wafers done, planned my way for surgery on the Thursday. Which those 2 patients, when people have their facial surgery done, there's carers at home, there's maybe time off work. There's the anxiety of having an operation. They've been waiting for it for weeks. And if he's told the night before, I'm sorry, but, can't do it, it's a great disappointment for the patient. And there's too much of that anyway, because of the theatre list get changed. King's is a major trauma centre. Major trauma comes in, they want the theatre to do major trauma, not the elective surgery. So we do get bounced around a little bit. But orthognathic surgery is one of my key skills, which we do quite a lot of. We've got a whole shelf, and we do loads of it, but a lot of it's done on computer these days.
So have you had to learn digital to go with that then as well?
We can do. I mean, it's so boring, in a way. It's everything's all wizard driven, and it's all it's all fascinating when you start it, but soon after it's just
and I think, like say, some of our more complex cases now, the clinicians are started dabbling with doing it digitally through one of those companies that we know of. But there's still a lot of our sort of standard osteotomies I'm still doing myself, especially like single jaws and some of the more simple bimaxes we do. But I think a lot of the industry, and we've discussed this in various other podcasts, haven't we, Jenna?
Yeah.
Are just going more and more over to the digital, and I think that's just something that we've just got to try and accept and embrace. But I know some people are concerned about the skills that might get lost as a result of that. Do you feel like almost people are de-skilling as a result of it, or do you think it's just a different set of skills?
Well, I went to I do an awful lot of CPD, and this wonderful one from Zircon. They did it on their digital dentures. The guy was, in fact, he turns out to be my age. He's exactly the same generation. And afterwards, I said, it's really fantastic software. I mean, some of the results that you achieved are far better than I've seen other digital dentures. I mean, they're like Kellogg's. They're dreadful things. They really are. And they really are not just, they really are awful. The teeth are awful. The pink's awful. The gum. So the people sexing it up and they're saying it's wonderful. I tell you now, it's not. But Zircon's on, they've got very good software. And he said, you know what, Ryan? He said, everything in that software, all the books I've bought, I said, yeah, me. I said, all the books you bought, all those books are in that software. Everything that we read about and learned and digested are in software. Just press a button and it works it all out for you with AI and algorithms. So yes, maybe they won't need it in the future, and it'd be a shame. The profession has changed dramatically. I don't cast silver anymore. I don't solder up locking plates. I do very little soldering during the week, maybe RMEs. And we've got nice laser welders now, so that's all kind of changed. So lots of skills we used to need are no longer required. They're nice to have, and I'm pleased that I can exercise them and practice them from time to time. But does someone coming into our profession need that now? No, I don't think so. But yes, those skills will be lost because they're not needed.
Quite scary though if somebody did have to go, if one day just, we had to go analog again and people don't have those skill sets because they just wouldn't know where to start or what to do, would they?
Well, that's right. That's why it's important that these skills are still taught through colleges, and they are trained. You got to understand what you're doing. It's not that monkey see, monkey do. There's a reason behind it. It's quite interesting. I've got a lovely colleague with me at the moment, and she's started about a year and a half ago now. Hospital trained, great technician. There's lots of things that she hasn't done or hasn't done for a little while, and I'm really enjoying that because I'm back to a bit of teaching, and she's very receptive about to learn. And you realise when people are asking you, you realise just on the depth of knowledge you have that you've picked up over the years. It's only by doing and by having to do and by innovating. And if you don't ever have that opportunity, then you're never going to get those skills and never going to get that knowledge. That knowledge won't be passed on.
Yeah,
That's a shame, really, isn't it?
Yeah. So, I mean, obviously, you've been in dental technology for, what did you say?
54 years.
54 years. I mean, that is a long time. You must have just seen such a massive amount of changes during that time. What's the one thing you don't lament going? What was the one thing that you were happy to see the back of during that?
Yeah, it's a good question. That I'm not sure anything that's back up. Chromes. I mean, I think chrome was never. It's a hard grind, and literally making chromes. I mean, I love the designs about waxing up and the smell of casting. That sort of very evocative smell in the nose. For polishing chromes, it's a hard graft. I don't know if people do it. Of course, now they got sintering. But having said that, it's out with all sintered now. They're all printed, aren't they? Yeah, well, not printed. They still need to be finished. Yeah, they don't come out nice and shiny, then people think they are. And this is the problem with going back to adding to the conversation about clinical colleagues and managers as well. It's all going digital, isn't it, man? It's just a press a button, it all comes out. No, it doesn't. I'll give you an example, like printing models. I mean, in fact, today we had a situation, you say about when the software fails, the license hasn't been renewed on our software. Today, we had no, we
I've
could.
been there.
Yeah. So what do you do?
Yeah.
Go back to mixing alginate and point out, and they say, oh, well, it must be really annoying for you because it's so much more work, isn't it, taking alginates? I say, no, it's not, because they're printing a model, and we had a few time and motion guys down to King's, and I'm open and I'm happy to cooperate because they need to understand what we do. They're going to try to hide behind it. This is what we do. And so how long does it take you to do from getting that STL file in to actually having a model in front of you to work on? You then got to duplicate back into gypsum, so you can't bend wire up on it, but that's another matter. How long does it take to get that plastic model as opposed to getting a model in gypsum? Well, easy. Pour up gypsum, half hour, rinse it, mix it, pour it on the bench. Within 30 minutes, you'll have a model you can work on. Not doing that with plastic, with printing. You can't.
It's a bit fun as well, going back to a bit of traditional every now and then, isn't it? You get to do a bit of casting.
And that plastic model needs to be landfill because it's not recyclable plastic. Even the tubs that comes in aren't recyclable. So it's not very environmentally friendly. You've got to print the damn thing. When it comes out, then you've got to wash it.
Mm-hmm.
Then you've got to post-cure it. And then, and it's a period, you get in a sequence, and you know that. But people think it's a press of a button and digital.
I have had this argument with reps before when they've gone in and go, oh, you can print X amount of models in X amount of minutes. And I'm like, but that doesn't give you a model you can work on, does it? Because then it needs to go into the wash unit for X amount of minutes. Then it needs to be cured for X amount of minutes. So actually it takes this many minutes before you've got a model you can actually start working on. And they go,
well, I think,
yeah.
They don't really mention the setting up of it either, because you've got to go onto the software and then you've got to set it all up on your build plate.
Yeah.
On the computer.
You've got to prep all the model,
send it all through, and it's got to do all of its calculations, and you've got to run through that, and then you can pop it on the print. But then you've got to make sure your resin's heated up, because we know with 3D printed resin it has to be at a certain temperature as well. Otherwise, it's not going to print well, and you can get misprints because computers, as good as computers are, they're not always 100%. And I think people forget that computers are made by humans. So they only can do what humans have inputted into them, but they can do them a lot quicker because they can chuck a load of different codes around all at once.
So, of course, the thing is with AI is that it learns from itself. It's exponential, it keeps learning, and that's not the danger, but they become very, very clever. But producing a dental device, I don't know of a computer that can produce a crib. Do we need cribs? A labial bow? Do we need them? All sorts of things it can't do, but they concentrate on the things it can do, which unfortunately are the loss leaders, not the loss leaders. These are the big ones that can bring in income to business. And if we go back to what you said about business and commercial laboratories, when people are knocking out, I use the term advisedly, knocking out retainers for 10 quid, they're just wiping out the income of many, many laboratories. And they're left with the big things like the trim blocks. But you can't make a living out of making trim blocks, as an example. And it comes to making complete dentures. Complete dentures in two visits. It's not true, because it's a copy denture technique. You're not going to start making complete dentures from scratch in two visits. That doesn't happen. But they're selling it that way. So, and unfortunately, when these things get in the market, fewer and fewer laboratories will set up, and all the lucrative stuff will be taken away, leaving nothing really. And these are the things which need the skill, and it does intensely worry me. I've got clinical colleagues at work. They've got printers. I've got a printer now. I said, what about the washing and the curing? Oh, it does it all in sequence. I don't know which one he's got, but you put it in there and it sends it, and they start printing retainers. I said, well, what's the point? Why don't you just pressure form a retainer, for heaven's sake? Why do you want to print it, wash it, cure it? You just put it on a pressure former and make it in. But they were fascinated because it's cheaper. They've got the lab fees, and that worries me intently. That you can reduce your lab fees reduce lab costs by doing this, by sending it to China, and there's a lot of that goes on, by doing it in-house, by getting your nurse to do it, and all these other things, which another multiple podcasts you've got to discuss with other people about MHRA, I mean, who's going to be regulating it, GDC regulation, scope of practice stuff. Yeah, it means, and all this stuff if you go back to what our podcast started, we've got about 10 minutes left, is that these qualifications, our profession, and it is a profession, I don't like the word trade, but people still use it, we call it a profession because my forefathers and people who come before me have tried to drag our technology out of becoming a plumber, a bricklayer, a plasterer, out of the trade, into becoming and it's slightly high level there because all the science that comes around it.
Yeah.
So it is a profession. They really worked hard to get that into a professional thinking it will do us good. People start respecting us as they do. Well, that hasn't. I don't think it's happened. I really don't think it's happened. I'm not too sad about that because the expectations about it happening wasn't really that good anyway. But that was the intent of making it a profession, get to a degree, we'd be on a par with dentists. Not a chance. And it's a shame that goes on. And the Facebook thing is really helpful because it's the same in America, it's the same in Australia, it's the same all over the world. The technicians lot is exactly the same. And basically, if you accept it, nothing wrong with it. I love it. I mean, I got no gripes. But don't think that we can hit that sort of professional level of the dentists would do. So this is why we as technicians need to promote our own profession. Get out there and go to schools.
Yeah, because I think we're not even classed as a skilled workforce anymore, are we? I believe
We're not.
Pretty sure. I read something that was it last year or maybe the year before that you know how you can travel to say like the likes of Australia and you can get a working visa as a skilled job role. I think they've taken dental technician off that skilled job role.
I don't think that they say, so when my impression of that kind of thing is the fact that it's not the same, we're not skilled. They change what professions they need over there. So they will sponsor certain professions because they're short of them at that time. Because I looked at moving, emigrating years ago when I was younger, and
as we all do.
yeah, and they were looking for them then, and they would have paid me to go over, etc. Whereas now I think they've got enough of those, and it's more important that they have others. So just on their list of skilled people they need, rather than just not so much people they consider to be skilled.
Yeah, that would be a lot better if it is that then.
Yeah, I think it is. Yeah.
Rolling back to your cases, have you got what's the most complex case that you've been involved with?
Oh, we got lots of funny things all the time, really. For example, there's one I did some time ago, a speech therapy device that someone was losing the. In fact, she had a car accident. She's a tennis player, quite a good tennis player, Greek, and she's losing wanted to sort of train her voice. And I made a device where you can actually, a piece of wire or a device was touching her soft palate at a certain pressure, and we adjusted it, and she could learn how to say a few words. And that was a moment of tearsful because she had some sisters and she had her carer with her. And her sister was very keen to see her treatment. It was on video on Facebook. And she managed to say, "Sister." Everybody was crying. I was crying saying it. That kind of thing. Yeah, going back to scanning, there's a similar case, actually. These things pass through. I just do them and they get done. Having a scan, there's a case similar to that recently where we had to know about the soft palate. And of course, with the scanner, you can scan the soft palate in a static, passive position. With an alginate, you're going to push up the soft palate, you're going to a mouthful of alginate. With a scanner, you can take like a picture of the soft palate in a passive state, which is really important when you start making devices. Another one the other day, we had a nasty lesion, which is on the hard soft palate border. Similar thing. So take a scan, and we get a beautiful plastic model with the hard and soft palate, and also the whole lesion is showing on the plastic. Not only that, when you look at it on the picture on the computer screen, you have a picture for the lesion in all its technicolor, exactly what you're working for. There's that one. But interesting cases, we often get dramatic orthognathic movements. We're talking 17 millimeters. 10 millimeters is in the range, 12 millimeters is pushing it. When we're talking about 17, you're thinking, no, it's not going to work.
It's a lot. That's a big movement.
So those things excite me when they come in.
Do you have a psychologist on board as part of your team with your orthognathic patients?
Sorry, Heather?
Do you have a psychologist as part of your team for your orthognathic patients? Do you want to explain to people like what? Because obviously I understand a lot about the orthognathic side, but a lot of other people won't understand like the massive impact and the changes that has on somebody.
It has. I mean, people think that it's going to be an improvement, and there have been cases, no cases that I've been involved with from other hospitals where the patient has been improved beautifully. I mean, what a difference. But they can't live with their new face, and that's the dramatic side. And these were some years ago, and this is why most hospitals now have a psychology input. Every single case, they have their appointments. They're making sure that they know what they're in for. And it's a big field. It's a big field. So we do. I know I have done thousands, been involved with thousands over the years. So.
Yeah, and it's massive, isn't it? And I've heard stories of people taking their own life. Fortunately, very rare, because they couldn't come to terms with the person they saw in the mirror anyway, because they didn't recognise themselves anymore.
Yeah.
Because, I mean, it's basically jaw surgery, isn't it? So you're completely rearranging not just the jaws, but all the soft tissue obviously moves and completely changes the dynamics of the face. I mean, I've seen more people going, oh, actually, I can do a bit better now. I've dumped my partner. But there is still that incredibly sad case every now and again that you hear where people just can't come to terms with it, isn't it? And it's heartbreaking.
Yeah, so the Gillies Unit, so we promoted Gillies Unit after Harold Gillies. There was a Gillies ward there at Queen Mary's many years ago when I was manager of the department, but when Queen Mary's changed, they closed down all the wards and made it a multi-sort health centre. The Gillies name was up for grabs, so we grabbed it, and it's the Gillies Unit, and we're very proud to be called that. We've got a bust of Gillies in our department, and we're following on the work that Gillies did from World War One, about really sort of changing faces and making a difference to people. But the department itself now is growing. We have a lot more restorative consultants there now. We have a special care dentistry there now, a community dentistry. We have undergraduates in the department. We've gone from 2 surgeries in 1976 when I got there. Yeah, it's now got 15 surgeries. So it's a big department.
That was big. That was big.
And we're going to sort of start expanding a bit further as well because the demand. So it's onwards and upwards. I'm very pleased to be where I am. Pleased to be a huge part of Queen Mary's Sidcup, and also a very proud member to be trained at King's. And in fact, I work under, we are run by King's. The King's NHS Trust run the dental services at Queen Mary. So it's all come together. One thing missing is a bit of teaching, but you never know. Might be to fit that in.
There's time there. There's time there.
It's nice to see after all these years that you still enjoy it and you appreciate your job and, the things that you're doing, because you do see some things on Facebook where some people that's ready to retire, they've just had enough and they don't like the profession anymore. So it's quite refreshing to see that you're
someone's still
enjoying it. Yeah, still really passionate about your job and what you do.
Yeah.
After 15 years as a lecturer and a course tutor, is there anything that with you doing teaching that it's taught you anything from that?
There's nothing. There's always things to learn.
You seem to have learned a lot, though, haven't you? I mean, you've just thrown yourself into learning from day dot, really.
The student's always got something to teach you. That's it. You never know it all by a long way. Yeah, it's every day. That's every day is a challenge, but you never know what's going to hit you that day. That information about something new. So no, that's all there is really. As far as that's concerned, it's got to be confident in what you're teaching. Don't try and make out that you know everything when you don't. If you don't know something, then go and find out. As a teacher, I think people respect you for that.
Yeah.
Do you have what's the proudest part of your professional career that you've achieved?
Proudest part, I think, gaining all 4 advanced qualifications was quite something. I rested on that laurels for some years. The teaching thing was excellent. It lifted me into a different sphere of professionalism. It's proper teaching. It's not, not a trainer. Just what we do this son and this how you do it. It's the education part, philosophy of education. And then just before King's took over in 2016, I'm so proud of the lab at Queen Mary's. And I was managing the department, and I knew I wouldn't be managing it for much longer, because when King's took over, they put in their own managers and et cetera, et cetera. That's when I decided to do the CDT course in 2013. But before then, I applied to, I submitted the lab for the most innovative laboratory and the best orthodontic laboratory to the Laboratory Awards. I thought, yeah, go for it. And I won on both. I was really chuffed that year.
Oh, well done.
So I went along, yeah. You think, you might stand a chance. But that was great. That was a great feeling. After all the years of Queen Mary's has been recognised. That's what it's all about. The lab has been recognised, because it really doesn't. You don't get recognised. You don't expect recognition. You don't have people come and pat you on the back every day.
But you played a huge part in that.
Oh, because my lab. I mean, absolutely. Yeah.
It's his baby.
It wasn't about me. It's more about Queen Mary's is the most innovative lab and the best orthodontic lab for that period. And that was a big moment, winning awards. But I don't really put myself up for that kind of stuff very much. So
No,
I might get an award for 25 years now. Because I started back at Queen Mary's at King's in 1999. They give you these special star awards for doing 25 years. The fact I've been knocking around for 54 is another matter, but
I mean, you started working 10 years before I was born, so I'm just like, I'm well out of my depth here.
This picture here is it's on my desk, and there's a reason for that. This is the lab at Queen Mary's, and the reason it's there because they did a sort of 50-year celebration. So have you got any pictures of the lab 50 years ago, Roland? Well, and I've dug that one. It's on my desk still. I don't know why, but there we are. It's a very, very small lab.
I love how even in a hospital or a lab, in a business, the colours are always the same, aren't they? When you look at these older photos, they're always yellows and creams and
yeah, it was, yeah,
deep reds or something.
Those walls were white, so I started to cast a lot. But no, I haven't painted yellow just on purpose.
I just wanted to ask another thing with when you've done all of these courses. I mean, how much time did that take away from you in general, as from your personal life? Was you up late at night with all your studying? Because it seems quite a lot to do all of these advanced courses that you threw yourself in from when 16? Was it 15?
Well, I might sort of pull up a little bit. It has taken. It has taken a lot. In hindsight, that was it. Just always working. And not only that, it's had the commercial side. I was very fortunate. I had when I got to Queen Mary's, the consultant said I've got my private work. So I don't do private work. I don't be silly. Well, and everyone does it. Do they? They do. All the hospitals are at it. Okay, so I did that, and obviously doing the Christian honest person, I set up a lab at home in the bedroom, which ended up in the garage. And so that was it. So you work in hospital, work in the evening, because you always get, I mean, either you do it or you don't do it. And you can't say, I can or I can't do it this week. You just do it as it comes in. And it's quite busy. I got a lovely home because of it. Very fortunate. Putting bricks and mortar, lots of study models have built this. Weekends didn't have weekends. I mean, no, it wasn't that bad, but I mean, it was always something to do at the weekends. One of those days at the weekend, I was in the lab because I don't know. I could have said no, but you kind of get used to having that income, used to having the holidays, used to having the nice car. You commit yourself to buying a house on that, and so it goes on. And then it's quite ironic. I laugh about it now. Quite ironic. I was doing all that business and running the Department of Queen Mary's and still running the lab at home. Then going on to do the most stressful part actually from that, you said about the time, was doing full-time work, CDT course. That was half a session, about one sort of clinical day a week. All the technical work, all the dentures you made yourself. So I was doing that, and I was doing the private work to fund the course and the whole time course and the whole time working. You don't know what you're doing. God knows what I was doing. And then that was all over, passed the course. Graduation was on February the 27th.
Memory.
On the Sunday, you're right, remember that Sunday, I didn't feel too good. Feel rough. Monday, my wife had said, you should go to the doctor. You really should go to the doctor. And I did. And ended up blue lighted to King's with a double heart attack.
Wow.
There we are. So it took its toll.
So what did you do about that then? So obviously once you recovered, because clearly you recovered.
Strangely enough, isn't that funny how everything seems to fall into place for me, doesn't it? Because the guy I was doing the private work for.
You seem to know a lot of people.
It was your heart surgeon.
Open doors, yeah.
I've been doing it for 40. He's a lovely guy, really, really friendly guy as well, really helpful. Good to work for. Whereas about payment or anything like that, it's always there. It's a really, really, very brilliant orthodontist. He retired. So I came out of about surgery, I think. Later that year, he decided to retire from his practice. So no more private work.
Mm-hmm.
I gave up the fags. Bad move that was. It's a bag, garage, fags, coffee. I can't stand coffee now. I can't stand drinking instant coffee. Cup after cup of coffee. And you just don't know you're doing it to yourself. You really don't. Mm-hmm. And maybe that's what it was. So, and then I gave up cigarettes and gave up the private work. And, so there we are. 10 years later, we're good.
Still here to tell the tale, and we're very pleased about it.
That's a good question, Johnny. It did take its toll.
Definitely. Yeah, it's something that we've kind of learned on several podcasts that these people that's put quite a lot into the profession. It's taking its toll on them, and it's taking things away from the family life and just personal life, and it's not helped them in other areas. So I think it's become one of the important questions really to.
Well, again, it worked out. It worked out well, but that kind of happened. Before that, I didn't have any children in my first marriage, and that this didn't cause the breakup of that marriage. That's something completely different. But I did remarry, and now I'm pretty fit and healthy. You see the exercise bike behind me, got treadmill downstairs. Yeah. Trying to keep myself fit, and 8 grandchildren later,
wow.
There we are. So
that's a lot of Christmas presents.
I was going to say they'll definitely keep you on your toes, won't they?
a lot of energy. So that's always very, very nice. So long may it continue, and long may I continue to do the job that I love. It causes me no stress at all. It's an enjoyable work, enjoyable job, enjoyable profession. Great team at the hospital. and interesting work and a variety of work. As I said, we keep building on the specialties at Queen Mary's from just oral surgery and orthodontics as it once was, or it's called MaxFac. Now we've got restorative, special care dentistry, all sorts of other cases being treated there, which come find their way to the lab.
Yeah.
So,
It's really lovely to see someone who's still passionate about the job and has so much love for it.
thank you.
What's one piece of advice then that you'd give to any young dental technician coming into the field?
Well, certainly enjoy it, study it, and learn as much, learn as many skills as you possibly can. Even if you don't think you might need them today, you'll certainly help you in the future. And listen to your tutors. There's some good tutors out there. Really don't do it half-heartedly. Read up in the books. Try some of the old techniques. And ask around to try and visit as many different laboratories as you possibly can. I know it's always very difficult in commercial labs because they're so busy. Try and get as much advice and pick up as much knowledge and information as you possibly can. It is going digital. There's no doubt about that. But there's a great demand for analog. I think digital has got a long way to catch up with some of the prosthetic work. I mean, a milling a crown or an inlay or an onlay, it's all done. That ship has sailed a long time ago. A lot to be done. But retainers, it's a bit boring. Who needs Hawley retainers anymore? It's all these sort of pressure formed retainers that are made. So that kind of skill is being lost. I don't know. I mean, the advice would be, if you're thinking about coming into the profession, look around, try and get involved with as many environments as possible, because it is a fascinating job. And it only takes a few places you realise that you'll be happy in, and you will be happy. You will be happy. But don't the role of sort of knocking things out, day-to-day grind. The old I was in the classroom for 5 years. That's all way gone now.
Come on, I've been in the printing room 5 years.
Yeah, with breathing all those fumes. But no, it's I don't know. It's what the future is for dental technology. There'll always be a demand for the bespoke stuff, all the good stuff. There really will. And you need to be one of those, as a young person, you need to be one of those who could do it, who has the knowledge, the capability, because not everyone will. So that's what I would say.
I think that's a lovely note to end on. I really appreciate you coming on. It's been a nice eye opener for me, because I didn't know anything. I didn't know anything about you, really. I'd never heard of you before. Andrea had mentioned you, and just hearing what you do and how you work in the hospital, I think it's brilliant what you do. Fascinating. You kind of feel like I need to pick your brains more. We could be here all night. Especially given you've got 4 advanced qualifications now, as on top of that.
Well, that's some time ago. That was 1980s, a long time ago. But they're good. They're hard fought by, hard ones.
But there's a lot of knowledge and experience behind all of that, and we definitely need that still in dental technology massively. So, thank you for coming on from me. Is there anything else from you, Andrea?
No, just to say thank you very much, Roland. I always love my conversations with Roland anyway, because he's such a genuinely nice guy with still a genuine passion for what he does. So, I do think we need more of that in the profession. And thank you so much for just coming on, sharing some of your knowledge and your experience, so others can benefit from it as well. But yeah, thank you for giving up part of your evening. Come chat to us.
If anything more sort of, this has been a very general podcast, but if there's any particular subjects you want to discuss in the future, and just drop me a line. See about it.
Yeah.
Well, if any listeners have got any specific things they want Roland to go into more detail in, then drop us a message, and we'll get you back on and do a special.
Yeah, special technical. Thank you very much.
All right, thank you so much.